Hi everyone, and thank you for joining me. My name is Loraine McGarrigle and I'm a physiotherapist working within the Department of Cardiothoracic Transplantation at Manchester University NHS Trust in the UK. I'm presenting this work on behalf of my co-authors, Dr. Gill Norman, Professor Helen Hurst, Loraine Gillespie and Professor Todd. We produced this work while I was supported by a pre-doctoral fellowship from the NIHR Applied Research Collaboration in Greater Manchester. Today, I'd like to share with you the findings of our systematic review, which explored a timely and clinically relevant question: can exercise-based rehabilitation interventions improve physical frailty in adults awaiting lung transplantation? Lung transplantation is a complex and high-risk intervention reserved for individuals with end-stage respiratory disease where all other medical options have been exhausted. Unfortunately, these patients often present not just with severe lung limitations, but often with physical frailty, a condition characterised by reduced physiological reserve. Frailty has profound clinical implications. It's associated with poorer outcomes both before and after lung transplant, including prolonged hospital stays, greater disability, reduced quality of life, and higher rates of rehospitalisation after transplant. Frailty offers a meaningful indicator of functional status and resilience, which is important as the average age of lung transplant recipients is increasing. Exercise-based pulmonary rehabilitation is already important and recommended as part of pre-transplant preparation, with evidence showing improvements in exercise capacity, strength, and quality of life. But what hasn't been clearly understood is whether these interventions also target physical frailty itself. That gap in knowledge was the impetus for this review. Our objectives were twofold. First, to systematically assess the effectiveness of any structured exercise intervention delivered by any means in modifying physical frailty in lung transplant candidates. Secondly, to appraise the strength of the current evidence, identify gaps, and offer direction for future clinical research and practice. This, to our knowledge, is the first systematic review specifically evaluating frailty outcomes in this patient population. We followed a rigorous process. The protocol was prospectively registered on Prospero, and the review itself adhered to PRISMA guidelines for transparency. We searched 4 major databases along with clinical trial registries from 1980 through to February 2024. Eligible studies included adults on the lung transplant waiting list undergoing structured exercise. We included a wide range of study designs, anticipating the rarity of RCTs in this area, and accepted both in-person and digital programs. Outcomes of interest were validated frailty measures like the Freed frailty phenotype or surrogate markers such as the short physical performance battery, gait speed, grip strength, and muscle function. We assessed methodological quality using an NIH tool for uncontrolled pre-post studies and evaluated certainty of evidence using the GRADE approach. Meta-analysis wasn't feasible due to heterogeneity, so a narrative synthesis was undertaken. We included 15 studies involving 664 patients. Interventions ranged widely, some delivered in hospital settings, others remotely via apps or telerehabilitation. Programs typically combined aerobic training with resistance or strength work, and a few included balance, flexibility, or breathing components. Only one study included dietary support. The key findings were the short physical performance battery, a common frailty marker, improved in most studies, especially in patients who were frail or pre-frail at baseline. Gait speed, 5 times sit-to-stand performance, and hand grip strength showed some improvement across several cohorts. Only 2 studies used a validated frailty phenotype as a primary outcome, and even then, certainty of evidence was very low due to small samples and lack of controls. Where balance and strength outcomes were reported, some improvements were evident, particularly in leg press and arm curl tests. No major adverse events were reported, but very few studies reported safety data. That said, study quality was generally low or fair. Most were uncontrolled pre-post studies with small sample sizes and suffered from heterogeneity in design, duration, and outcome reporting. This greatly limits the strength of any conclusions we can draw. So where does that leave us? Overall, exercise-based rehabilitation appears to offer benefit in modifying surrogate markers of physical frailty in lung transplant candidates. Both in-person and digital programs show promise. However, the certainty of this evidence is low to very low. There remains a pressing need for high-quality RCTs to assess whether these interventions truly improve frailty, and crucially, whether they impact post-transplant outcomes like survival, recovery, and independence. Clinically, this review reinforces the importance of offering structured rehab, ideally with aerobic resistance and balance elements, to all patients awaiting lung transplantation. We should also recognise the potential of digital and hybrid delivery methods to widen access, especially for patients facing travel or physical limitations. But we also need to do more work as a research community. Future trials should report clearly on frailty-specific outcomes, consider multimodal interventions including nutrition, and explore if programmes need to be tailored to different lung diseases. Equity matters too. Frailty is often worse in socio-economically disadvantaged patients, yet these groups may face the biggest barriers to rehab access. Future work evaluating ways to improve access and adherence is needed. This is a rapidly evolving field, and I hope our work lays the foundation for stronger evidence and more effective, inclusive care for lung transplant candidates. Thank you.